enjoyed the courses were wonderful. I truly loved my class with Dr. Abdi Kuso on race and ethnic relations. I loved my class with Dr. Yilem Tishom in anthropology that I took. I wanted to take majors classes again and again. I ran out of them. The ones on social change and development, the social change and development, actually that's the highlight. That's why I selected it as my area of specialization. And believe it or not, even though it was a very stressful process, preparation for my first prelim, the sit-down 5-hour exam prelim on social change and development, enriched my knowledge greatly because I read through Monopoly Capital by Paul Sweezy. I read countless works of social change and development. I read Chambers. I read lots of very good work that allowed me to see both the trends of the literature but also really getting in depth on all the various theories. So about sustainable livelihoods, or the political economy of agriculture a little bit, something that I didn't know. I don't have much of a background in because I don't have much of a background in agriculture, but once they start talking political economy, my ears perk up. And so I really enjoyed that process, even though at the time I was very nervous because a lot was riding on it. So I've enjoyed the coursework. I enjoyed the meeting Dr. Peters too late, really getting to know Dr. Peters too late. He has so much to teach people regarding quantitative methods. My dissertation is entitled Resource Distribution, Accessibility, and Health Equity from Global Analyses to the Cuban Case. And it is divided into 3 separate research projects that look at various aspects of those phenomena, right? So how resource distribution in terms of human resources for health, mostly. Accessibility, how do we provide access or prevent access to healthcare systems through our financing mechanisms of healthcare. And health equity is certainly a key here in terms of health outcomes, whether we're talking about infant mortality rates or inputs such as the human resources for health, physicians, nurses, etc. So the first paper is a multivariate regression analysis that pulls on data from 186 countries around the globe. And the data comes from the World Health Organization primarily, but some of the data for GDP comes from the World Bank, or GNI per capita, which but what I wanted to see and what I'm asking in this paper is, what is the relationship between government expenditure on health as a percentage of total expenditure on health and the infant mortality rate? So that's the key guiding question for the first paper. And the reason why that predictor variable was important is because it's also a measure of accessibility. The government expenditure on health as a percentage of total expenditure on health is inversely related to out-pocket expenditure on health, which is a component of private expenditure. And it also shows how public versus how private healthcare financing is in a given country. So what I did was I gathered data on that from the World Health Organization, gathered the infant mortality rate data, gathered data on physician density, gathered data on the percentage of the population with access to improved water sources, and the percentage of children under a year that have received the polio vaccine. ran all the bivariate correlations, looked at which variables were likely to be the largest predictors. There was another variable that we ended up dropping because it didn't have any even a significant correlation, and that was a total expenditure on health as a percentage of GDP. A lot of people might think, oh, that's a really key indicator for health outcomes or for health expenditure. But what I found is, no, it matters sort of how that's divvied up between the public and private sectors. It also matters, according to previous research, how governments use those funds. That was a limitation because I didn't have data on that. I didn't go into that. But what I did find is not only a strong positive correlation, strong inverse correlation between government expenditure on health and a percentage of total expenditure on health and the infant mortality rate, but I found that this association was fairly robust. It did experience a decline in somewhat in significance. It remained statistically significant with the number of countries we had, but there was a decline in the effect size when the GNI per capita was logged and in the same model. But that's to be expected, because if you take GNI per capita and you log it with the way we did it with the log 10, or even if you do the other way, it's an exponential increase in GNI per capita in a country's resources. So that has a big impact to go from a poor country to a very rich country. And some of that led me to examine if there was an interaction effect going on. And we found I'd say we, referring to my committee because they were always there, a significant interaction effect, which meant that government expenditure on health as a percentage of total expenditure on health mattered more in poor countries than in wealthy ones. The second paper was a nested typology of 123 developing countries in health and development. And so there I had a couple more variables, including the Gini coefficient and the percentage of children under 5 underweight. And I had all the other variables that I previously mentioned, except for polio. This time I looked at DPT3 vaccine, but basically the same, a similar set of variables, but this time just non-OECD or primarily non-OECD countries. I had some places like Mexico in there, and Mexico is now part of the OECD. Chile is part of the OECD, but they're not what we think of developed or wealthy nations. You don't usually think of Mexico, particularly with the problems that Mexico has, or the steep inequality of Chile. And if you look at their nurse density, it's far lower. It's an outlier among the OECD, or their physician density is also an outlier. And so the problems of brain drain are already implicit in paper 1 and then in paper 2. So paper 2, what I did was a cluster analysis. I used Ward's method, and this paper was co-authored with Dr. Peters because I gave him the co-author credit. He helped me with the SAS programming. He's actually the one who taught me how to do cluster analysis, how to interpret cluster analysis, helped me make sense of the data. And so I extended credit to him for that. And so we did this hierarchical agglomerative cluster analysis using Ward's method. Well, that's a fancy way of saying we measured the distance between, or the statistical program measures the distance between cases in each cluster as they combine, trying to minimize the distance between groups of countries that are or trying to maximize the distance between the groups and minimize the distance within the groups. So what you want to do, the ideal cluster solution, is one that explains the most amount of variance, but with a parsimonious model. Finally, the last paper is a look at Cuba. It's a case study. And what about Cuba's healthcare system was I particularly interested in? Well, it was human resource for health distribution over time and space. And I say over time and space very deliberately because I wanted to examine the trends in the distribution in terms of inequality measured by Gini coefficient and the tile index in order to get an idea, is this distribution becoming, are they able to maintain this level of equality in their distribution, because there's been discussion particularly about the impact on the distribution based on Cuba's medical collaboration abroad, but also because of the significance, and mostly because of the significance of brain drain and concentration of physicians in urban areas across the globe. And so the fact that a country with few resources, few economic resources, they have a lot of human resources for health, as we'll see, but has been able to achieve what they've achieved in this regard is notable. And that's why I selected it. And I actually demonstrated this quantitatively by taking some of my data from the earlier papers and running a regression line with physician density as the predicted variable, and just taking the GNI as the predictor, because we know that since both governments with greater resources have the ability, or countries with greater resources have the ability to train more physicians, but we also know they attract more physicians. So you would expect that a country like Cuba would by that measure would be lower, but so we know that they're above the average. So I show the error, how much above their predicted value the real value was, and so that was an important way to kind of justify where I'm going with this. Regarding students, there were several that are no longer here because they already have their PhDs in all cases, but one that were people that I really admired. And although I lived off campus, I didn't have that much contact. That was a drawback because I live in Des Moines, commuting to Ames limited my personal interactions with people. But I still had several with Annette and Rashawn and Joseph Manuel, and then also a little bit Diego. So those students, I found that they would be very supportive and so wonderful. The people that I would meet in Mazur's class, all the people I took Mazur's class with. Mazur's class was wonderful because of it. He'd have the group projects, he would do them in a very creative way. So not only was it a wonderful experience for me as a student, but it gives me ideas for how I want to teach social change development in the future. Because he would come up with group projects where everybody would play roles of the key stakeholders, and then he'd create a scenario and say, how do you address this from the position of the stakeholder? And those were always interactive and thought-provoking exercises. And there was always a little bit of humor with Rashawn and myself and others. So that was an enjoyable part of Iowa State.